biomedical engineer extraordinaire, Jordan Schuff, is going to take it away with our slides.
Yeah, can you guys see my screen okay?
Great, looks great, yes.
Okay, yeah, myself, I'm a biomedical engineering student, and then we have Dr. Venkatesh here, who's the Chief Medical Officer at Aravind Eye Hospital. We're going to be telling you about Vizilent today.
Thank you. Thank you, Jordan. Yeah, this is our first pitch on the Vizilent. So you all know the global visual impairment, the burden of the visual impairment across the globe. We have 1.2 billion, and almost 1/3 live in a country like India, 340 million. And most of it is kind of preventable, almost 80%. If you see this, the map, a distorted map of blindness, the prevalence of visual impairment is so huge in the low middle income countries, as we discussed earlier, whereas the number of practicing ophthalmologists is kind of inverse. You don't have that much of human resources. So to reach the unreached, next slide, Jordan. So we do a lot of outreach activities. So to reach this kind of problem. So cataract, as you all know, is the largest cause of global blindness, and a simple surgery like a cataract surgery, which takes less than 10-15 minutes, can restore the vision. Annually at Aravind Eye Care System, we screen roughly 500,000 patients to do 100,000 cataract surgeries. In spite of doing this, we have seen a lot of limitations. We have seen that only 20% of patients who need eye care in the zone where the outreach happens really take the care, because it takes place at specific dates, specific times, and in specific locations, still finding it difficult for access to certain people because of the distance, because of the cost, and also the time related. So, and also some of these outreach have high reliance on highly trained eye care professionals, a team of doctors, paramedical, they all have to go there. And some camps are very successful, and some camps really become a big flop because of various reasons, and resulting in a kind of expense due to staffing, logistics, and also the marketing towards getting these patients to the campsite. Next slide, Jordan. And more so in the last 2 years, when the pandemic was happening, all the outreach activities were kind of stalled. No, we didn't have permission to do outreach activities. So almost like 500,000 Aravind patients could not access eye care. So almost you have to double this number in the last 2 years, but in between we were able to do a few camps. And this delay kind of led to a late stage, like advanced stages of cataract, even resulting in secondary glaucomas and blindness related to that, which complicated the process. And recently, the government of India released that there is an estimated backlog of 10 million cataracts in the last 2 years, which has to be cleared this year, in addition to the new cases we have to do in 22 and the years to come. So that is where we came up with this kind of a solution called Aroma, Aravind Rural Outreach by Mobile Application by the Vizilent Group. And now I hand over the stage to Jordan to continue the presentation.
Sure. So just to summarize the barriers that Dr. Venkatesh listed, there's access to specialists, distance to facilities, high cost of screening, and general lack of awareness. So we looked at what a solution might need. We interviewed a lot of stakeholders and patients, and we understood that a solution needs to be de-skilled and decentralized in order to make sure that it's reaching the people in the remote areas. It also needs to be low cost, and ideally a solution will be community driven so that we can increase awareness about access to eye care. And so that's where we came up with this Vizilent with this Aroma project, which is an integrated end-to-end patient outreach and diagnosis system, which is optimized to serve eye care systems in low and middle income countries in order to reduce the incidence of preventable blindness and integrate underserved patients into the eye care system. So this solution consists of several components. First is a low bandwidth field application that enables minimally trained users, such as community health workers or volunteers, to screen patients in the field, either door to door or at high traffic areas in their community. And with the mobile app, community health workers can collect and upload ocular history, complaints, visual acuity, and capture anterior segment images. So these images are standardized using a smartphone attachment. that can capture diagnostic level images of the eye. And here you can see some examples captured by community workers with less than 30 minutes of practice. And when we had 2 ophthalmologists review these, they found that 95% were of sufficient quality to make an accurate referral. And then using these images and other information collected from the patient, we're developing artificial intelligence algorithms for real-time referral decisions in the field. In a proof of concept trial where we used low quality images captured before we optimized our imaging hardware, we were able to achieve a precision of 92%. However, we've now built a database of 2,000 high quality images. So we're working to develop a more robust algorithm for real-time diagnosis in the field. And then this app seamlessly connects to a backend electronic medical record, which enables ophthalmologists at the base hospital to review information and, if needed, make a final diagnosis and referral decision. And then finally, and probably most importantly, in order to close the loop, Visilent allows for automated communication, both through messaging and through phone call. So the patients can be easily contacted, referred, and given the proper treatment. And over the course of developing the system, we've screened over 2,000 patients. We also conducted a paired validation study at Arvind against a gold standard in-person exam compared to our telemedicine exam with Visilent. And we found that community health workers are able to accurately collect information. They were measuring visual acuity accurately in 95% of cases, and that a remote ophthalmologist reviewing information collected by community health workers can accurately diagnose patients in 93% of cases. So we plan to continue to develop the system alongside our partners in India in order to meet the needs of the eye care systems and the patients there. So first, we're going to build upon our previous work and develop robust algorithms for real-time diagnosis in the field. We will evaluate these algorithms in an 1,000 patient paired validation study against a gold standard in-person exam. Next, we'll develop a pipeline for interoperable integration into hospital medical record systems. Our goal is to make sure that we're fitting into the hospital workflow and that we can ensure patients are following up, complying with their treatment, and receiving the treatment they need. And then to further aid in this goal, we'll also develop data dashboards to track outreach patient outcomes and make sure that we're reducing the burden on already limited staff at eye care systems. So our goal is to make the system available and sustainable for hospitals. In order to do this, we're planning to charge a $2 to $3 referral fee for each patient who receives treatment as the result of our screening. And this will ultimately be lower than the $8 hospitals are currently spending to bring in these patients. So really quick to wrap up, I'd like to thank Arvind for this collaboration, thank all of the amazing investigators involved in this project, as well as the team of students and the people on the ground at Arvind making this happen. So thank you, and we'll take any questions at this time.
Thank you, Jordan and team. We'll turn it over to some questions, and I'm going to take them in order, starting with Alan Labreek. Do you have a question for the team?
Yes, thank you for that excellent presentation. My first question is going to be about equity and reach of the solution. Have you looked into the availability and penetration of WhatsApp in the population hardest to reach in this area, and will you be able to reach them with this solution?
Yeah, so we interviewed around 60 patients last time we were in India. And you're right that there wasn't high WhatsApp penetration. So from that, we pivoted. In fact, many of the patients we talked to said that they were illiterate and they would have a hard time if they were getting messages reminders. But they said that if they received automated phone calls, that would be ideal for them. They also, the majority of patients, over 90%, said that either they or a close family member had a phone so that they could get that follow-up information.
Thank you.
Thanks. Julie, you have the next question. Do you want to go ahead?
Yeah, I was wondering about the potential for scaling. It seems like there might be a bit of a limiting factor with the referring ophthalmologists. So I was wondering how you envision scaling this across hospital systems.
Sure. So that's where the artificial intelligence comes in. Our goal is to ultimately relieve the burden on ophthalmologists in cases that can be handled, that are really standard and can be handled by a computer-based system, to use that, and then to limit the reviewing ophthalmologist to the cases where there's either a low confidence level or it's a more complex case, not like a standard cataract, in order to make sure that this is scalable to hospital systems.
Great. Tom, your question.
Yeah, a great presentation, and you covered a lot of ground. I just wanted to find out of the sort of the specificity of the ocular problems that you might be able to pick up. I mean, your focus has been on cataracts, but what about visual acuity? What about blepharitis? I mean, those ocular exams should be able to detect some of those. How are they going to be incorporated into some of the referrals?
Sure, I can start, and then if any of the ophthalmologists have anything to add, please jump in. So the way that we're designing our algorithms at this point is they don't just use images, but they also use the patient history, they also use the visual acuity, and they use all of that really valuable clinical information we're collecting. So that'll definitely help us to distinguish these different conditions. So at the time, we are currently diagnosing cataract, both immature and mature, as well as refractive error, corneal infections, trauma, and pterygium. So the most common and probably the most impactful cases in these rural and remote communities.
Great. So I think we're now at time for the questions. We'll start the next set of questions. Tony, you'll get the first question next time. That was a great presentation. Let's give a round of applause and thank you for that.